Hello and welcome to our new topic, one of the most complex ones. Today we will explore anti-cancer drugs, one of the most complex yet clinically impactful areas of pharmacology. Unlike many other drug classes, cancer therapy is not about single agents, but about combining drugs strategically to target rapidly dividing cells while minimizing damage to normal tissues. So, let's start. In this lecture, we aim to identify drug targets, classify anti-cancer drugs, and understand their pharmacokinetics, mechanisms, adverse effects, and uses. However, beyond these objectives, the real goal is to develop a clinical mindset, to understand how oncologists choose drugs based on tumor biology and patient factors. A malignant neoplasm or cancer can be understood as a defiant tissue, one that no longer responds to normal regulatory signals. It continues to grow, invade, and resist apoptosis. This abnormal behavior explains why cancer requires aggressive and often multimodal treatment strategies. This diagram summarizes modern approaches to cancer therapy. Traditional methods such as chemotherapy and radiotherapy target rapidly dividing cells, while newer approaches like anti-angiogenic agents and targeted therapies interrupt specific molecular pathways such as growth signaling and blood vessel formation. This represents a shift toward precision medicine. We can see in this diagram that different anti-cancer drug groups act within a variety of targets in a cancer cell. For example, anti-metabolites act within the nucleus, alkylating agents damage DNA, microtubule inhibitors disrupt mitosis, while monoclonal antibodies and TKIs act at the cell membrane or signaling pathways. This spatial understanding helps us connect mechanism to drug classification and clinical use. In summary, different drugs target different vulnerabilities within the cancer cell. Only a small proportion of tumor cells are actively dividing and susceptible to chemotherapy. Quiescent cells in the G0 phase act as a reservoir and are difficult to eradicate, which explains relapse after treatment. Cell cycle is an important aspect when anti-cancer drugs are selected, because different anti-cancer drugs interact with the cell cycle differently and provide a variety of advantages and disadvantages. Some drugs act in all phases, hence are called cell cycle non-specific, while others act only during an ongoing cell cycle, sparing the interphase. Therefore, such drugs are called cell cycle specific. Yet, there are additional drugs which can only act during a specific phase of the cell cycle, such as S or M phases. Thus, the phase-specific drugs require precise timing, proving useful especially for rapidly dividing or aggressive malignancies, whereas non-specific drugs can act at any time and can be effective not only for aggressive malignancies but also for indolent and slow-growing cancers. The log-kill hypothesis is a concept which explains that chemotherapy reduces tumor cells logarithmically, not completely. Each treatment cycle reduces a fixed proportion of cells. Hence, curative chemotherapy should be designed in multiple cycles at specified intervals. Certain factors modify the requirement of chemotherapy. For example, if a tumor debulking is carried out surgically, even less number of chemotherapy cycles could be effective. This slide also highlights the fact that in many cancers, diagnosis is possible even before the symptoms are noticeable, thus emphasizing on screening programs for earlier detection and more successful treatment. Most anti-cancer drugs are anti-proliferative, meaning they target dividing cells. However, they have limited effects on differentiation and metastasis. Tumors with a high growth fraction respond better to phase-specific drugs, while those with a low growth fraction require non-specific agents. Drugs with different mechanisms and toxicity profiles are combined to improve efficacy and reduce resistance. Ultimately, success depends on tumor type, stage, resistance, and patient condition. Hence, chemotherapy is about strategy, not just drugs. This slide lists major classes of anti-cancer drugs. Each class targets a different cellular process, from DNA synthesis to mitosis to signaling pathways. Modern additions include targeted therapies such as tyrosine kinase inhibitors and monoclonal antibodies. Now let's start delving into this subject even deeper. We begin our discussion with antimetabolites. These drugs target metabolic pathways in nucleic acid synthesis. This table compares common antimetabolites. Methotrexate blocks folate metabolism, while 5-fluorouracil, cytarabine and 6-mercaptopurine act as false nucleotides. These drugs are particularly effective in rapidly dividing cancers. The side effects also involve rapidly dividing cells, such as bone marrow and mucous membranes. Methotrexate inhibits DHFR, preventing tetrahydrofolate formation and halting DNA synthesis. No folate means no DNA synthesis and no cell division. Inhibition of folate metabolism affects normal cells as well, particularly bone marrow, leading to myelosuppression. This is a major dose-limiting toxicity. Luckily, there is a way to recover the damage to the normal tissues, as we see in next slide. This animated diagram shows the involvement of folate in 1-carbon pool metabolism, all depleted by methotrexate. Folinic acid, marketed as leucovorin, bypasses DHFR inhibition and restores folate pathways in normal cells. Cancer cells respond less effectively, allowing selective protection. This is selective rescue of normal tissue. Among the antimetabolites, some drugs are analogues to purine or pyrimidine nucleotides. These drugs mimic natural nucleotides and get incorporated into DNA. They may also bind with enzymes involved in chain elongation, thus causing chain termination and halting replication. Examples include 5-fluorouracil, cytarabine, 6-mercaptopurine. Antimetabolites may also synergize with each other. Combining drugs like methotrexate and 5-FU enhances anti-cancer effects by targeting multiple steps in nucleotide synthesis, multiplying the efficacy. Alkylating agents are a widely used drug class. These drugs form cross-links in DNA, preventing replication and transcription. They are cell cycle non-specific and effective in aggressive and indolent tumors. However, there are serious side effects, both immediate and delayed. One such delayed toxicity is causing secondary malignancy. For example, breast cancer patients treated with cyclophosphamide run a risk of therapy-induced acute myeloid leukemia several years after receiving the treatment. Nevertheless, they are a group of valuable drugs. Cyclophosphamide ultimately generates phosphoramide mustard as the active alkylating moiety. This causes DNA cross-links between the strands or within the same strand, causing failure of DNA replication. Cisplatin also acts in a similar fashion. Now let's continue with anti-cancer drugs from natural sources. They act by diverse mechanisms. In this table, we focus on anti-cancer antibiotics, isolated from a variety of Streptomyces organisms. Anthracyclines are the most important group. Anthracyclines intercalate into DNA and generate free radicals. Their major toxicity is cardiotoxicity, which is clinically very important. Unlike cross-linking, which is a chemical interaction, DNA intercalation is a physical interaction, in which drugs insert between DNA bases, disrupting structure and function. This table lists all other drugs from natural sources. Etoposide inhibits topoisomerase. Vinca alkaloids inhibit microtubule formation. Taxanes stabilize microtubules. And enzyme asparaginase deprives malignant cells of essential amino acid L-asparaginase as it enzymatically converts it into ammonia and aspartic acid. As could be noted, any drug that interferes microtubule function would produce neuropathy because microtubules perform a crucial function of intracellular movement, such as of neurotransmitters from cell body to synapses. Microtubules are essential for chromosome separation during mitosis. Disrupting them halts cell division. At the time of DNA replication, DNA unwinds, starting from the replication fork on both sides. As it unwinds, DNA supercoils accumulate. DNA topoisomerases help relieve supercoils. Inhibiting topoisomerase prevents DNA unwinding, leading to replication failure and cell death. Etoposide acts by inhibiting topoisomerase II. The microtubules are targeted by anti-cancer drugs to block mitosis. They are made up of alpha and beta tubulin subunits. A positive end is where new subunits are added, while a negative end is where they are removed from the microtubule. Anything attached to microtubule, such as chromosomes, would move by virtue of this harmony of addition and removal of subunits, called dynamic instability. Blocking any of the two processes would disrupt the microtubule function. An animation would demonstrate this dynamic instability in the next slide. Vinca alkaloids inhibit assembly, while taxanes prevent disassembly. Just follow the white spheres, depicting something attached to it, as it moves due to this harmonious assembly and disassembly of microtubule subunits, creating a mechanical motion. This slide introduces targeted therapy. Imatinib inhibits BCR-ABL kinase, while monoclonal antibodies such as trastuzumab and bevacizumab block extracellular receptors or ligands. Note that monoclonal antibodies act outside the cell, while tyrosine kinase inhibitors act inside. A diagram on the next slide explains it even better. This diagram shows that monoclonal antibodies block receptors or ligands at the cell surface, while TKIs inhibit intracellular signaling pathways. Immune checkpoint inhibitors restore immune response against tumors. Thus, targeted therapy interrupts signaling, not just cell division. Today there are many anti-cancer immunoglobulins and tyrosine kinase inhibitors are available for solid tumors as well as hematological malignancies. This table lists them according to their therapeutic target. Another table is given on the next slide. The list continues here also. This slide shows which anti-cancer drugs are commonly used for solid tumors, lymphomas and leukemias, making a variety of therapeutic regimens. Just note that cancer treatment is disease-specific and combination-based. By now, you must have noted that chemotherapy has so many adverse effects. That's because chemotherapy lacks selectivity and affects both malignant and normal cells. Moreover, it doesn't completely eliminate all cancer cells, as shown in log-kill hypothesis, and resistance often develops. Hence, chemotherapy involves multiple drugs and multiple cycles, followed by long follow-ups. Finally, let's summarize major side effects and their typical treatment approach. Many adverse effects are managed with supportive measures only. Cyclophosphamide is an example where hemorrhagic cystitis can occur due to a toxic metabolite acrolein and can be prevented by using mesna, especially when high-dose chemotherapy is used in hematological malignancies. In breast cancer, where only medium doses are used, hydration alone can prevent hemorrhagic cystitis. I would end this lecture by reminding that cancer therapy targets DNA, metabolism, mitosis, and signaling pathways. The choice of therapy depends on tumor biology, growth fraction, and patient factors. Remember that to treat cancer, targeting multiple vulnerabilities simultaneously is the key. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!